Thank you, chairpersons, and I'd like to thank Rama and the PCSF for giving this opportunity. I will review the literature and discuss about the ASD closures in elderly. We all know, and we are quite happy to offer a surgery or intervention to child with a ASD. We have no confusion about that. We often get confused, or patient often asks, "Will I benefit?" When we see a 40-year-old lady with a volume overload, but she says, "I have not incident detected," then one is often confused, and it is even more difficult sometimes to answer a question to a patient who is a 50-year-old and who has already developed arrhythmia, and then once gets a little bit. Are we going to benefit or not? I think that is what the question is. I will try and review the literature on that. So we all know the ASD has a very good outcome. Closer has a very good outcome, and early outcome young are very fairly good. And most of the people who are suitable would go for intervention, and if not suitable, then would go for surgery. That we all are aware of it. Coming to the ASD with elderly, what is the question? Why with age deteriorates? It's mainly problem with decreased LV compliance, with the increased left right shunt, increased incidence of atrial arrhythmia, development of pulmonary hypertension, and RV. We all know the pulmonary hypertension is quite uncommon in ASD. If one has ASD with severe pulmonary hypertension, we are probably looking for two diseases with rather than a single disease. And incidence of severe PH is uncommon to the tune of 5 to 8%. We all know that. So, and again, back to the same question in elderly, one need to assess patient's LV function, even more important, LV diastolic function, and one needs to control hypertension. In such individual, we will often land up doing angiographies in this patients, and renal function also needs to be looked at. So, if the patient has a heart failure at 50 years with ASD often provides protective effect by pulling a propofol and hemoglobin. So, will I worsen by closing this ASD? That is the question we often ask these patients, and we or sometimes gets confused, and we may not be able to offer the correct answer. Uh, we all know that the deterioration starts about third or fourth decade, and main symptoms are worsening because of dyspnea, arrhythmia, rarely embolism and infection. And the definition of elderly is, I think below 40 years the benefits is fairly good. Beyond 40 years, there are some group who decide beyond 40 years. There are groups who be divided beyond 60 years. Survival is quite thing, and we all know the patient as with increasing age beyond 60 years or so, all they will develop atrial fibrillation, tricuspid regurgitation, and are higher in this. That we all know about that. If you see the slides, if 40 years is probably I think important to cut off when you counsel the patient, and if you have a patient with below 40 years, the incidence of pulmonary hypertension and heart failures are not that common, or that not important factor. While as the patient crosses 40 years, the more chance for develop pulmonary hypertension, heart failure start worsening. Besides arrhythmia, which were there anyway below 40 years of age in such individual, and makes life more difficult for such patients. In this study, where they have studied this study tells us that if the patient is below 25 years, the outcomes are fairly good, and between 25 to 40 years, it's another good, and beyond 40 years, the long-term outcomes, irrespective of the outcome surgical, are not so good as one would like to have below 40 years of age. Again, this just represent the slides. Below for 25 years, and the pressures are below 40 years, 40 millimeter mercury, the outcomes are completely different in the group. And as you can see from the slides, after 25 years of age, the incidence of atrial fibrillation are increases significantly beyond in given patients of ASD in such individual. So we all it's a mere the echo and ASD. One needs to control the hypertension. But I think hypertension is quite significant problem in such individual, and if appropriate when given situation, would like to give diuretic. I'm not very particular fan of ACE inhibitor, or I wouldn't give simply because the patient has ACE inhibitor. I'm not sure it does really benefit, but that been mentioned that ACE inhibitor should be given. I probably would give it if the patient has hypertension. Otherwise, simply ASD, I would not give it. All the patients who have a significant shunt ideally should be considered for closure. And although we all know that as increases patient become more heart failure. The surgical mortality keeps on increasing. We all know the mortality in most series is fairly low, and every unit has its, or every cardiologist has his own decision. We all know what is operable and what is not operable. It has been well upon very significantly. With the one, probably the important message would be, if the peer pressures are more than 50%, one shouldn't touch the patient with very seriously. Needs to reassess or discuss before setting up the patient for a surgery. And interventions are fairly good, and there's a lot of patients are there. So coming to some of the literature, there's a fairly good amount of data that in about 200 patients on operated, we can see from the slides that over the period of time with age, a fairly good amount of patients develop heart failure, sudden death, and the heart is there. And these have shown the higher trends of sudden death, and that we all know that. In another study, 10-year survival, so surgery has definitely shown benefit. And you can see from this study that if you operate even 50 years of patients, 10-year survival is far better with surgical results compared to medical follow-up. So the naturally trend is in favor of that. And if you we should counsel them that there is no way we can tell you that probably atrial fibrillation is unlikely to get reversed beyond 40 years of age. And there is a strong possibility that it will reduce, but it will probably not go away. And we should counsel the patient that atrial fibrillation arrhythmia will persist in seizure. There is another study which clearly shows the benefit, symptoms as well as the RV dimension and early functions has been shown to significant improvements are there in this. I think the age, again, we come back to the 40 and 60 years, and then there are fairly good amount of data. And main question is atrial fibrillation is the important, besides hypertension, is the important decision making process in this coming to outcome in the such patients. So if we have to choose, naturally one would, there is no question about it. One would choose the ASD device because device is surgical has its own problem and more thing, but. Uh, Overall, if the patient is not very sick, the surgical model is also quite good. We all know the imaging guidelines of the. So, in summarize, beyond 40 years, I would say even the patient is asymptomatic, large shunt is there. Current data suggests that one should subject to the patient for surgery. There are some, and as I said, so naturally, device is far better than a surgery if it's feasible and compatible. But I wouldn't touch the patient if the pay pressures are more than 50. Then I would be very nervous or jittery about closing such device. It will probably leave them alone with a pop-up wall rather than putting a device in such patients. Uh, Imaging is mandatory. All of us do it. It's mandatory, and I would recommend all of us to do T. And I do all T for adult ASD, unlike the children with that. I don't have personal experience with a patient who has ASD with LV dysfunction or a closer. But if you're a patient with a large ASD with LV dysfunction, probably one should make an attempt at temporary balloon occlusion and see if the LVED pressure rises, and he will tolerate. And if it's so symptomatic, one could think of financial ASD, but I personally don't have any experience with this. But it could be one of the options. And I don't recommend the patient. I have a couple of patients with LV dysfunction. I tell them I probably won't do it. And but one could do temporary occlusion, and financial device are there. We have extensive discussion on the closure of PFO. I'm not going to discuss that. To summarize, if I have a patient with ASD and is symptomatic, I still, irrespective of age, I would still recommend a closer, provided that her hypertension is controlled and the patient does not have a significant pH. I would still recommend, and if naturally, device is far better than a surgery. Thank you very much for your opportunity and kind attention. Thank you.